Can you see and hear me okay?
Yes.
Okay. I'd also like to thank Dr. Shivink and Dr. Deline for the invitation to speak today. The title of my presentation is CT-guided fibrin glue for CSF venous fistulas. And over the next 20 minutes, we'll have three main learning objectives. First, to briefly discuss Decubitus CT myelography because it's so closely related to the success of the fibrin glue technique. Secondly, we'll discuss how to perform the fibrin glue technique. And then lastly, some tips for successful treatment. So how do we do Decubitus CT myelography in our shop? Well, we first review the spine MRI for the laterality of the meningeal diverticula, but we usually choose the right side to start because we witnessed fistulas more commonly occur on the right side. We position patient decubitus with a sponge on a CT table, and I'll show you that in a second. We scout the total spine and ensure an adequate 10 to 20 degree Trendelenburg angle. Do a lumbar puncture, check an opening pressure. We inject 0.5 cc's of Omnipic 300 as a test dose and then inject 9.5 cc's of contrast afterwards. We do not inject saline either before or after the contrast. We scan immediately the total spine, 0.625 millimeter slice thickness and a standard kernel, and we sometimes repeat additional runs at the fistula site with inspiration. And then if a fistula is not seen, we scan the contralateral decubitus either on the next day or on the same day. And this is how it looks like at our institution. We're in the CT suite. Here is our custom made wedge. Patient's head is here. They're in the decubitus position and they're laying, their legs are laying flat on this part. And this is what you want to see when you do your scout radiograph, a nice 10 to 20 degree angle, so that when you perform a lumbar puncture, contrast will flow down the spine with gravity and maximum ensure filling of the diverticula. The Duke group first published this, and then we published our technique, which is very similar last year. And here's some examples. 46-year-old woman, SIH for 4 years, conventional CT myelogram at the T10, T11 level, bilateral meningeal diverticula, no fistula. We even did an MRI myelogram with intrathecal gadolinium, which we don't really do much anymore. It was also negative. And then on the decubitus CT myelogram, you can see this nice fistula because of the decubitus technique. It's really important when you do decubitus CT myelography to scan right away after you inject contrast. Here was a complex fistula we identified after scanning immediately after contrast injection. Same patient, 3 minutes later, fistula is absent. So the temporal resolution really matters in these patients. And if you puncture under fluoro and then send the patient to CT or do a DSM and then do a CT, your chances of seeing the fistula on CT are less likely when you have a delay. Now, as Peter mentioned earlier, there are various flavors of CSF venous fistulas. You have small fistulas arising from small diverticula, fistulas arising from large diverticula, long venous courses, and sometimes even multiple veins. And why does this matter? Well, it affects the treatment planning. So getting good images to show the fistula course is really paramount. Some advantages of decubitus CT myelography. Well, moderate sedation versus no sedation at all are needed. So unlike general DSM, which you may need general anesthesia, moderate sedation is the only thing or none at all. You can image the entire spine, so CTL. You don't have to focus on a particular area. There's an easy learning curve, I think, for most operators. And then lastly, the 3D localization really helps with the CT-guided glue treatment. So with that, let's go into the CVF treatment. This is actually an image of our very first patient we diagnosed with a CSF venous fistula at the right T9, T10 level. We sent the patient to neurosurgery, and our neurosurgeon identified the vein, and he ligated the vein and also the nerves, and the patient actually did well, was cured. We had a second patient with a fistula. We did the exact same thing, cured via neurosurgical procedures. Then we came to this patient, and it was a 72-year-old woman. She was actually a retired radiologist, and she had a textbook-looking CSF venous fistula draining into the azygos vein here, and she was terrified of having surgery and just would not have at it. And she asked us about percutaneous treatments, and we were very upfront and candid with her and told her simply the data and the research shows that it's really not successful, and we shouldn't, we're not really optimistic on trying. She pleaded with us. We tried a combination of blood and glue, and it wasn't successful. She asked us to do it again, and it was successful. And since that patient, we've had a whole paradigm shift for treating these. Here's a different patient with a CSF venous fistula on Decubitus myelography. Here is the fibrin glue occlusion. Here is the needle, injecting it in the neural foramen. We mixed contrast with the glue so you can actually see the glue. And then we performed a follow-up myelogram about a month later, and you can see the fistula has resolved. Clinical symptoms resolved, MRI also resolved. Here's another patient, almost a very similar looking fistula. Here is the fibrin glue occlusion filling the neural foramen. And in this patient, we also got glue within the vein of the fistula, which is a really good sign to see. You don't have to see that to be successful, but it's a really good sign if you do. And similarly, follow-up myelogram shows resolution of the fistula. We published our results earlier this year in radiology. So let's go over the technique of how to actually do it. Position the patient prone and scan at the fistula level. We place a 20-gauge spinal needle at the junction of the meningeal diverticulum and vein. And please note that if you do the glue in the same session as the myelogram or in a different session, regardless, the fistula will be gone by the time you actually do the glue procedure. So we base our needle position on anatomic landmarks. We do a test dose with air or iodine contrast, and this is good for two reasons. One, it ensures you don't inject in the wrong spot. And then two, if you need to tweak your needle to make it even better, you can do so before you inject the glue. We add a little bit of Omni 300 into both hubs of the glue so we can actually see the glue. We inject 2 cc's of glue in one shot. We do a quick scan and then inject 1 to 2 cc's or more if needed. If the patient has received fibrin glue previously, we will administer some Benadryl to mitigate any allergic reaction. And these are all the supplies you need, a whole 2 things. Here's your 20-gauge needle, and here is your fibrin glue. And this is how it looks like in the patient. Here's the needle, and simply connect the glue and inject. Here's a little cine clip of the fibrin glue. You'll see a needle here and then filling the neural foramen with contrast enhanced glue. Here is another example of fistula, left T11, T12. You'll see some squiggly veins with arrows there in the neural foramen. That's the fistula. Then we injected fibrin glue in the same session as the myelogram. So here's the myelographic contrast. And then you'll see a needle here with contrast enhanced glue. And then here's the follow-up myelo. An arrow just denoting the meningeal diverticulum, but no fistula. Pre-procedural MRI, thick dural enhancement. Post-procedural MRI shows resolution of dural enhancement. Fibrin glue occlusion can also be performed at the high thoracic level. Here was a CSF venous fistula at the right T1, T2 level. And note that there's all this surgical fusion. Patient had likely an associated venous malformation that was causing cord compression and had to have that removed. So you can imagine doing surgery on this fistula may be a little tricky, and even this high thoracic approach may be tricky with an endovascular approach. On fibrin glue technique, though, we inject our needle here, glue within the vein, and then the follow-up myelo, meningeal diverticulum, but no vein. Fibrin glue occlusion can also be used in the emergent setting. I remember this case very vividly. It was an early Saturday morning. We weren't on call, but we got called for this patient who was in coma, had very bad brain sag, and had central herniation here, bilateral uncal herniation, and patient was not responsive. We did a myelogram. You can see a classic fistula there. We did the glue injection. You'll see a needle here with the contrast enhanced glue. Patient actually recovered very drastically, was discharged from the a neuro ICU in hospital within a few days. He came back to see us in a month, resolution of the fistula, resolution of the brain sag, resolution of the central herniation, and he was very emotionally happy of the outcome. As mentioned earlier, CSF venous fistulas can sometimes even extend into the bone. You'll see a fistula rising here at T12, L1, and you'll see it course into right here within the bone. We then target the needle in the same exact fashion, very, very medially, and then you'll see glue within the bone in multiple different areas, even a paraspinal course and into the azygous vein. So it can even target the fistula if it has a intraosseous course. We like to think there are at least 10 different advantages of fibrin glue treatment. First, it's a 45-minute outpatient procedure. Moderate sedation is all that's needed, no general anesthesia, and there's minimal recovery time after the treatment. Most patients are able to do the things around the house and get back to their normal activities. Greater than 95% of the time, there's only one needle used, and I'll show a case where we use more than one needle later. It may be done anywhere in the spine, including the high thoracic and cervical, as mentioned. And you can target the various forms of CSF-venous fistulas. So as Dr. Kranz mentioned earlier, sometimes you have that fistulas drain into the internal epidural plexus, which could be tough to target with other treatments, but you can target with the fibrin glue. It can be performed in the same setting as the CTM or in a different setting, and it can be repeated if initially not effective. There's an easy learning curve, and I think most people could learn how to do it, and it can be performed at a large or even a small center and throughout the world, so not just at the quaternary SIH centers. As mentioned earlier, CSF fistulas are sometimes shy or very fickle or sometimes you're not really questionable. You're not really sure if it is a fistula. It may be hard to justify more invasive treatments, but it's easy to justify the fibrin glue treatment. The glue does not result in any artifact on subsequent CT exams. You can't even see it. So that's an advantage, unlike some other materials. It's very inexpensive. I think each box of fibrin glue is around $200. And now that we know rarely that patients can develop additional de novo fistulas, it may be easier than having more than one invasive procedure. Our follow-up at our institution is dynamic CT myelography in 1 to 2 months, if possible. And we do this because we want to prove it to the patient, to ourselves, and to others that this treatment actually is effective. And then we do a brain MRI and a clinical follow-up in 1 to 2 months. And here are our cases to date. Over the past year and a half, we've had 28 patients treated for CSF-venous fistula with fibrin glue technique. I think that's a decent number considering we're a closed healthcare network. So we cannot treat patients outside of our hospital network. 19 patients had 1 session of fibrin glue, 8 patients had 2, and 1 patient had 3 sessions. 19 of 19 patients had final post-treatment mylos that showed resolution of the fistula. Post-treatment MRIs showed improvement in all patients with abnormal pre-treatment MRIs. We've had clinical improvement or resolution in all patients except 1, and that patient may have other factors. We've witnessed that fibrin glue within the vein of the fistula is a good predictor of treatment success, but you don't have to see it to be successful. We've had no major complications. We've had to send no patients to surgery since the advent of our fibrin glue, and we've had no patients requiring retreatment after fistula resolution. So I think some may be wondering, why are our results different from prior literature? Some may feel that I tried this before, but it didn't work for me, and go to another arm. Well, I think a few different reasons. One is the technique. While you can do this under fluoro, given of how much precision and accuracy you need to have, you're probably more likely to be successful with CT guidance. Test injection is probably one potential reason, and as I mentioned, it can help dictate where you want to adjust your needle if needed. Mixing contrast with the glue so you can actually see it may be a reason. We've also noticed that a more obtuse needle angle when you inject the glue is better than an acute angle because it permits more filling of the neural foramen. And lastly, and probably most importantly, needle targeting the fistula nidus at the diverticulum vein junction is probably the most important factor in determining success. And I'll show a case here why that matters. Here was a 76-year-old man, had very large subdurals, right T12 L1 fistula. Here was a suboptimal needle position that we did. You can see the needle is very dorsal compared to the fistula. Here was the glue we injected. Here was the follow-up myelogram, persistent fistula. And then on the next go around, we had the needle more ventral at the expected location of the nidus, injected the glue, and fistula resolved and subdurals largely improved. So needle position really matters. Real-time manipulation of the needle may also be helpful. Here is a fistula. Here's the air epidurogram and that we injected, and we're actually really happy to see this. Then we injected the glue, though we didn't see glue in the vein. So we just rotated the needle a little bit and re-injected, and now you can see glue within the vein and the azygous vein, and patient improved very quickly. Glue occlusion can also be used for complex fistula. This is a really pleasant 50-year-old woman, had a meningeal diverticulum here, fistula, right T11, T12 level, and then went all the way up to the T10, T11 level. Here is the glue procedure. We injected at 11-12. Though the patient had residual symptoms, so we did another myelo, and actually the follow-up myelo is even more showing how complex it was. You'll see a little vein here, and then you'll see an intraosseous course here, and then the main needle nidus there at 11-12, and then it's going up to 10-11. Then we injected fibrin glue, 3 levels. There is 12-1. 11-12, 10-11, and then here's the follow-up myelo, 12-1, 11-12, 10-11. And this patient improved from her SIH. She is encountering some rebound pressure, which we are currently addressing. As far as future directions, we'd like to obtain longer clinical follow-up and potentially establish multi-center prospective trials. I'd just like to briefly mention, this is our algorithm for Northern California Kaiser. We start off with a positive clinical and MRI brain. We do a total spine T2 fat sat. If there is an extradural collection, we do dynamic ultrafast CT myelography, either in the prone or decubitus position, very low volume of contrast. We find the leak, percutaneous treatment. If that's unsuccessful, we'll send the patient to neurosurgery. If the MRI is negative, we'll do Decubitus CTM, find the fistula, and do percutaneous treatment. And as mentioned, we haven't had to send any of those to surgery after that glue technique. If the D-cube is negative, we do multi-level non-targeted blood patches, usually in the thoracic spine. So in conclusions, fibrin glue occlusion is an effective, easy, and inexpensive treatment option for CSF venous fistulas. Targeting the needle position directly at the fistula junction is probably the most important factor and main key to success. And with that, I'd like to thank you for your attention.
Thank you very much.